Quick, for those of you guys that are in clinicals, I'm just going to ask you, some of you already have sent me a phone number. The rest of you guys, I brought in the clinical group sheet. I need a phone number before you guys go home, just because since we're doing several different groups, we want to make sure that we have contact information. So I know Rita had asked specifically for the PEDS group that's starting group 4, make sure she has their info since she wasn't able to be here. So just before you go, if I don't have your phone number already for clinical, I've got the sheet to put it on. And thank you to those that responded to my emails about sending me some stuff. So, we're back. Does it feel like Monday though? I know. To me it's sort of weird because I was here all weekend with the first semester lab. So yesterday just seemed weird. I couldn't figure out whether it was Sunday or Monday yesterday. I couldn't, it just felt weird because I was here going full tilt all weekend, and yesterday I did nothing. I watched TV, I read, I did some knitting. I vacuumed a couple of rooms, and that's about all I did. Great. Okay, so today we're going to start talking about acute and chronic pulmonary disorders. Today the focus is going to be on pneumonia and tuberculosis. Pneumonia is generally considered acute. Tuberculosis can be acute or chronic. We'll go ahead and get into what else went on with that. I have a couple of mini case studies that we're going to do during the course of the class today to go with the content, just to give you guys a chance to talk about what we're going over and get you thinking a little bit. All the talking up here. It's going to be a little bit of a change. So we are going to start with a question. So while caring for a patient who is receiving oxygen therapy for pneumonia, what should the nurse assess to determine if the patient is hypoxic? Choose the best answer. You guys remember this from? Okay, how many people think restlessness? Just raise your hands. Okay, cold hands. Confusion and non-compliance. Okay. How many of you don't know and you didn't raise your hand? Or don't want to take a guess and think, if I raise my hand, I'll look silly. You won't look silly, It's what we're doing is trying to just get an idea of what's going on. What's some signs and symptoms someone was saying? I thought I heard something. So the best answer for hypoxia is confusion. Can anyone tell me why? Yes, Sarah.
It's because of lack of oxygen in the brain.
Does what?
When you get the low perfusion.
Yep, the perfusion goes down, the amount of oxygen in the brain decreases, and one of the cardinal signs of that is confusion. Very good, thank you. Restlessness, maybe, but think about, with patients. What does someone, if they're in pain, what are they doing? They're all over the place, right? Especially if they can't get comfortable. So that may be a sign, that there's some hypoxia going on, but the best answer for this is confusion because that's caused by the decrease of oxygen to the brain. Okay? Good. So some basic information. And some of this, I didn't put stuff in the slides or anything. I'm going to have you review like the anatomy and physiology on your own. Know the terms at the beginnings of the chapters. Those will help. So review anatomy and physiology on your own. You should know the anatomy of the respiratory system. The physiology, you need to know how breathing works. Okay, so you need to know your terms like ventilation, diffusion, alveoli, bronchial tree, all that stuff that goes with respiratory. So I'm not going to take the time in class to review that. You can do that on your own. You guys should all have had anatomy and physiology, right?
Yes.
A lot of you have had health assessment already, so you already have a lot of that information. So some of the diagnostic studies, and I'll tell you when I got looking back, there's a typo in the readings. I forgot to include the section with this, but this is just more review It's just some of the things that we do for people with respiratory disorders. Pulmonary function tests are a big one. How much can the lung, how much can you inhale, so how much the lungs hold, how well you're able to empty the lungs, that type of thing. We do sort of a mini PFT every time we use what? Anyone know? Spirometer, right? We're giving the spirometer to the patient, and the patient goes, well, my belly hurts. Yeah, I know your belly hurts, but you got to do this. So they start out, maybe if they're lucky, they get to about 500, and as they get feeling better, you see your little marker, you can raise up and up and up and up. It's a very crude PFT, but for our purposes at nurses, it helps us see, one, where someone is at, and two, how well they progress, and how well they're able to do what we want them to do, which is deep breathing. Arterial blood gas studies, or ABGs, also help because what they do is they show us how much oxygen is in the blood, how much carbon dioxide is in the blood. We look at sodium bicarb, also look at pH. Okay, so we're looking at different things to help determine what the body is doing and how it's functioning. I'm not going to go into doing ABGs. I know those of you, if you've taken the class before, Melinda really went into how to do them and how to figure them out, and respiratory alkalosis versus metabolic acidosis and stuff. For the purposes of this class, I'm not going to go into them big time like that. But know that that's one of the things that we look at. What makes an ABG better than just doing a venous puncture and getting info from that, do you think? Where's the ABG coming from? What? Where? I can't.
It's oxygenated blood that's being pumped straight from the heart.
Yeah, so where's it coming from? Yeah, but in the
Arterial.
it's coming from an artery, right? So this is blood that hasn't gotten rid of its load of oxygen and picked up more carbon dioxide. This is coming right out. It's in the process, but it gives us a better picture of how much oxygen is being carried in the blood. Why can't we just use a pulse ox? Anyone know? What does a pulse ox measure? It measures saturation on the hemoglobin, right? Has anyone ever taken care of anyone that came in with carbon monoxide poisoning? You can have SACs in the upper 90s with CO poisoning because the carbon monoxide molecules bind to the hemoglobin. All the pulse ox is measuring is how much of the hemoglobin has something bound to it. Okay, so for the most part, it works fine for us. It gives us an idea of how somebody's doing, so it's not, pulse ox is something we want to make sure that we're monitoring. But there are times when it may not be giving us a true picture. Okay. Cultures, we're going to have, with the respiratory issues, throat cultures, nasal cultures, sputum cultures. And a sputum culture is not just when you give somebody a cup and they go, patooey, and a little bit knocks into the cup. Where do you want a sputum culture to come from? You want it to come from deep, into the trachea, into the bronchial tree, into the lungs. You want stuff actually coming up from there. So, if someone calls for a sputum culture and you send one down, it didn't do it correctly, then you'll get a little call from the lab saying, oh, we got saliva in this. That's all we got. You need to get a sputum culture. Like, okay. So that's when you call respiratory therapy and have them come and suction somebody and get them to cough really good and deep, and then you can get a sputum culture. But what we're doing is we're looking to see if there's anything in the respiratory system, down in the lungs, that shouldn't be there. Okay. So I feel constrained. I don't have my clipboard. Imaging, we're going to do chest x-ray. A lot of stuff will show up on x-ray. What do lungs look like if you have clear lungs? What's it look like on an x-ray? Anyone remember? It's black, right? Because it's air. So anything that's in the lungs is going to show up generally as like a milky white if you see something in the lungs. CT and MRI are also used for diagnostics. Yes, Kelly?
It's easy to see the heart in a chest x-ray, right? Or
Mhm.
can that be confused for something else?
No, just because of the shape and the position. And, you know, if you've got any experience in reading them, no, you know, you couldn't because it's so, what's the word I want? Distinct, I guess. A good question though, because it does show up looking different, you know. You can see the heart behind the sternum
On
and
the
sticking
other
out.
hand, it can prevent you from seeing things
That would be behind it.
So for instance, lung cancer most commonly forms around the hilum, which are the entry points of the main stem bronchi into the lungs, which is right where the heart is. And so sometimes you might miss something there because you assume it's part of the peripheral sac.
So some other diagnostics you may see when you're doing stuff, you know, with people with respiratory issues is bronchoscopy, where they take a tube and they go down and they look down into the bronchi of the lungs to see if there's something going on. Thoracoscopy and thoracentesis, where they're going right into their chest cavity, looking at stuff. Thoracentesis is you're actually draining stuff from the chest or the lungs. And then biopsies, pleural biopsies, lung biopsies, and lymph node biopsies. So what these mean to us more is, you know, knowing what the tests are looking for, you know, what they're going out and having this stuff for, but we're looking at what are we doing as nurses when we have patients that are going through these things. Okay? What about with the bronchoscopy? Anyone ever had one? Anyone ever taken care of a patient that had one? What do they do, Ryan? What do they go down for?
Well, they're conscious during the procedure.
Okay.
Um,
What?
And
They're NPO before, yeah, because they do have some sedation because they want them to relax.
Right, as well as afterwards.
Mhm.
They want to wait till a gag reflex returns.
Right? Because they want to numb that because of what? What do they do it?
It's going down.
Well, it
the
hurts
throat.
and they're putting a tube down your throat and your instinct is to start to gag. So, as nurses, you have somebody coming back that's had a bronchoscopy done. So what's the first thing you need to wait for? The gag reflex back, to come back. You need to make sure that that's present because you don't want to give them something right away and have them choke on it and aspirate. Because then whatever problem they've got, you're going to exacerbate because you're going to get water or wet food in their lungs. So you need to know and think about the things, and when you read about these, think about the things that as nurses we're going to do with this patient. Someone with a bronchoscopy. Beforehand, you know, you make sure they're NPO. Make sure that, you know, you're answering questions. Is it a consent procedure? Yep. So who gets consent?
Doctor.
The doctors. We don't get the consent, but we can witness that they have given their consent and they understand what's going on. So say a patient comes up to you and says, well, I really don't, you know, the doctor came and talked to me and I really don't know what's going on and I wonder what's going to happen afterwards. And can you tell me all that? What do you tell the patient? Are you going to sit there and tell them all that stuff that
No.
could go wrong or whatever? What's your best answer for that?
The doctor will be in soon to give you that information.
Or, you know, I'll let the doctor know that you have these concerns. Because, you know, if someone is sick or in pain or scared, are they going to always hear everything that's told to them? No. So, you know, you can make sure that the person is comfortable with the knowledge that they have going in. And that they understand, you know, that understanding is there, but your biggest job is to listen to what they're saying. Make sure that they've stayed NPO. You don't want them to get sick and aspirate. When they come back, you know, watch their airway, obviously, right? They've had something stuck down their windpipe, into their lungs, look around. Watch their airway, wait for their gag reflex to come back. I know there's been, you know, people that do bronchoscopies, they talk about some of the stuff that they find in the lungs that you wouldn't think. Thumbtacks, push pins, paper clips, little pieces of toys and little kids, you know, like these little Mixo Lego thingies that the pieces are this big. grandson has 15 different characters now. It's like, okay, but the little kids like to swallow, you know, they put those in their mouth and they inhale and they swallow them. I saw a picture once of somebody that had aspirated a pea. He was eating and a pea went down in his lung. It started to grow. And they found it when they scoped him. So it's, you know, what they're doing is they're going in, usually, you know, most of them I've seen have been for people that have inhaled something, but they also go in because it's a way to get a look at what's going on inside the lung. And so if they suspect that there may be cancer or something like that going on, they can go in and look. So, but again, as nurses, what we're doing is, you know, we're doing what the patient, we're giving the patient what they need, not as much medically, but physically, psychologically, emotionally, giving them that support. So, pneumonia. I liked this poster. This is from the First World War. Pneumonia strikes like a man-eating shark. Makes you think, doesn't it? So consult your physician. It's led by its pilot fish, the common cold. So, pneumonia is defined as officially inflammation of the lung parenchyma. So the lung tissue becomes inflamed. That's what pneumonia is. There's 4 types of pneumonia, and that's for those of you that have the 6th edition chart 23.3, and I can't remember what it is on the 5th here, so I'll have to double check. But what you have 4 types that we usually see. Community-acquired pneumonia. That community-acquired means exactly what it says for the most part. People that are just out going about their daily business, or people that are less than 48 hours hospitalized. Corey, you put your phone on, please.
Yeah, I'm recording for people that aren't here, sorry.
Okay. So community acquired is people in the community or 48 hours or less hospitalized. So they're either people that are out doing their thing, or they're people that have come into the hospital and have only been there a day or 2, and they develop pneumonia. That's called community acquired, okay? Healthcare associated is non-hospitalized patient who is in long-term care, has had antibiotics within the previous 30 days, is on hemodialysis, home infusion, something like that. There's something going on with that patient and their health status that makes them more susceptible to pneumonia. Then you have hospital-acquired pneumonia. Someone gets this after more than a 48-hour stay in the hospital, but they appeared to not have the infection when they came in. So they didn't have it when they came in. It hasn't been developed in the first couple of days, which would make it community acquired. And so they're in there more than 48 hours and they develop pneumonia for whatever reason. Okay. That's hospital-acquired pneumonia. And then you have ventilator-assisted pneumonia, which is if someone is put on a vent and they're on a vent for more than 48 hours, they can develop pneumonia from that. So like with any other procedure, when someone's put on a vent, the goal is to get them off as quickly as possible. We know the longer they're on it, the more risk you run of developing pneumonia, and then you have the comorbidities that go with that. There's also aspiration pneumonia, but that's considered in a different category than what we're looking at. That's where you swallow something, whether it's gastric juices or your little kid swallows a toy or whatever, and it goes in the lungs. That's aspiration pneumonia when it's caused from an outside factor like that. Oops. So by the numbers, I thought this was sort of interesting. 2011, 52,294 deaths from pneumonia. Anyone know what pneumonia goes together with a lot of times, especially in the elderly? Just a FY, a little factoid, but if you know. Influenza. Influenza and pneumonia tend to go together, especially in elderly patients. The average hospital stay in 2010 for a patient with pneumonia was 5.2 days. Okay. Hospital inpatient deaths from pneumonia in 2006, of all deaths in the hospitals, 2.4% were from pneumonia. But now we have pneumonia shots that we tell people if you're over, 60 or 65? 65 at least. Or if you're younger and have some sort of comorbidity. That may make you more susceptible, if you've had cancer, if you have lupus, if you have diabetes, anything like that that can, make you more susceptible to developing pneumonia. We tell them to get it, as a young adult. But
One that's on the rise is measles,
yeah.
believe it or not.
Yeah. So, yeah, because people, and that's a whole nother story, but people either aren't getting vaccinated or are traveling to places where measles is rampant and haven't been vaccinated or had it. And we bring it back. So, but the number of adults who have had pneumonia shots as of 2012, they were looking at 59.9%. So we've got a little ways to go, but little by little, people are realizing that it does make a difference. Long-term care, yeah, Kelly.
Is there any disadvantage to getting a pneumonia shot? Like, anybody can get a pneumonia shot? It's good for them?
I don't know that there's a disadvantage, but they're looking at it more for people that are more at risk. And a young, healthy person is generally not considered at risk. So again, you don't want to get something if you don't need it.
There are contraindications, that's what they
But like I said, if for young, healthy people, you have a very low risk of developing pneumonia, so they don't look at it as a need. But the older we get and our immune system starts to wear down, and then like I said, people that are compromised in other ways, yes, they.
Like if you have asthma, you should get.
Asthma may be one because you already have an airway issue, yeah. But like I said, anyone like with diabetes, with lupus, with cancer, with anything that affects the immune system like that, or so that's the type of thing you would be looking at. Okay. Long-term care through 2004, which was the latest study that they had here, pneumonia is the second leading cause of death. It's sort of scary, isn't it? I think you get old people, they're going to have heart attacks and strokes and stuff like that, but pneumonia is the second leading cause of death. It's the leading cause of hospitalization in nursing home patients and long-term care patients. And at pretty much any time, almost 2.5% of the patients in our client population will have pneumonia. So, one of the things that people have been researching and have been finding out that is contributing to the amount of pneumonia in long-term care is this: nursing homes neglect to eat. Anyone remember seeing this article about a year ago, the Star Tribune?
I brought it in.
There have been studies done about oral care and long-term care settings, how much it is neglected. And we know that with neglected dentition, you've got a lot of flora in your mouth already, right? There's natural bacteria there. They belong in your mouth. They don't belong in your bloodstream and in your lungs. And what happens is people, their teeth get bad, they're not cared for, those bacteria get into the bloodstream and end up in the lungs, and that's where a lot of pneumonia comes from in the elderly, because of that lack of dental care. So, they talked about a woman who was visiting her dad, who was a World War vet with dementia, in a nursing home. This is in Virginia, okay? She said she had been visiting him for months and then noticed dust on his electric toothbrush. Okay. His teeth, she found, had not been recently brushed, so she began doing it herself after their lunches together. But after he complained of a severe unrelenting headache, she said she badgered the staff to make an appointment with this dentist. And a lot of places will have dental, personnel come in, directly to that nursing home. The dentist found that a tooth had broken in two, and he showed for the woman the part that had lodged in the roof of her father's mouth. Okay, so, and of course, like I said, he had dental insurance, he had been acting out and stuff, and staff was inferring that it was because of the dementia. Here he was in pain. And no one had been doing oral care, to check to see if what was going on. So, in nursing homes across the country, residents suffer from cavity, gum disease, and cracked teeth in part, not totally, but in part, because their mouths are not kept clean. While residents now require more dental care than in the past, nursing home employees are rarely prepared to provide it. That doesn't always mean that they don't want to provide it, but those of you that, especially if you worked in long-term care as a nursing assistant, right? There's one or two of you for 20 or 30 residents, aren't there? I know, I've worked long-term care, I know what it's like. It's one of those things that you do the best you can, but sometimes, like oral care goes by the wayside. But we have to start changing that culture, because that's leading to more illness that's unnecessary, right? So the biggest issue, like they said, is that, when it's harder when you have people with dementia. They may not cooperate, some teeth, let's brush your teeth, first goes, clamps down. So you really have to pay special attention to people that aren't able to do, their own oral care or aren't able to let you do that. So it's just one of those, like I said, one of those things. I read that article and I was just flabbergasted. Because, let's see, roughly 1 in 10 cases of death from pneumonia in nursing home residents could be prevented by improving oral hygiene. 10% of the pneumonia deaths in residents, just by helping them brush their teeth and, making sure that you're at least observing and seeing what's going on inside their mouths. So some other risk factors: age. We know the older you get, part of it's your immune system, but what else is age-related that might contribute to pneumonia?
Immobility.
Immobility, but think physiologically. There's less elasticity in your lungs. So what does that do? You have your cough is decreased. You don't have as much strength. You aren't able to breathe as deeply and to keep things going in and out. Good. Comorbidities.
Postural changes as well.
Postural changes as well, and especially if you're hunched over and things get sort of crunched up and aren't going to expand and contract as well. That's correct. Comorbidities. We talked a little bit about that. If you have a previous illness, it's going to make you more susceptible to pneumonia. Immunocompromised. When HIV first was really starting to be recognized for what it was, one of the biggest things that people found in HIV patients was pneumocystic pneumonia. You don't see that usually in regular population. But again, you have immunocompromised patients that were developing this type of pneumonia. Malnutrition. Think about it. If your body isn't nourished to keep it healthy, are you going to have the strength you need to fight something off? You got a cold, it turns into something worse because you don't have the reserves that you need. Positioning, like Ryan said, you get someone, if they're hunched over, if they're always in bed and, maybe laying in one position and not moving. And then hospitalization. Again, a lot of times in the hospital you get someone that's not able to get up and get moving. They may have had surgery or may have had something else go on, but they're having pain and don't want to deep breathe and cough. So you have that risk factor as well. Also, we know that there's a lot of bugs running around the hospital that, have gotten worse over the years, right? So the pathophysiology. The causes of pneumonia in are usually, in compromised patients, are going to be caused generally by normal respiratory tract flora. And then you also have the oropharyngeal flora, but Streptococcus pneumonia is one of the main causative organisms for pneumonia. Other causes, Haemophilus influenza, Mycoplasma pneumonia, and my son is very proud of the fact that he had this when he was 7 years old. Got it at the swimming pool, believe it or not. Cytomegalovirus can cause pneumonia. Herpes simplex virus, Pseudomonas. So those are some of the things. So in outpatients, usually people with community acquired, it's going to usually be the strep pneumonia. That's mostly what they'll get. That and the mycoplasma. In hospitals, you're going to see the Pseudomonas, Haemophilus influenza. You may see Legionella, which can cause pneumonia. So there's a difference in what the causative factor is, and whether you're in the hospital or outside in the community. The oropharyngeal flora, we just talked about that a little bit when I was talking about this article about oral care. And then any exogenous substances, stuff that comes from outside, so chemicals, gases, stomach contents, other little Lego toys, thumbtacks, whatever ended up in the lung there. So ventilation and diffusion are affected. So you need to remember what ventilation is. Anyone remember that? Ventilation is what?
Air. Breathe.
Air comes in and out, right? You breathe in, air goes in, you breathe, so you're getting oxygen in, you breathe out carbon dioxide. What's diffusion?
Movement of oxygen.
From a higher concentration to a lower concentration.
Okay, and where does that happen?
In the alveoli.
The alveoli, right? So you breathe in, you got the oxygen coming in. In the alveoli, you've got all these little spaces, lots of surface area that help the oxygen crosses in to go into the arteries to go into circulation. The carbon dioxide comes out. And it happens, in the systemic circulation, you have to come back to the lungs, and that's where then the main exchange happens. So what happens when you have inflammation is your alveoli become compromised. And we see this also like with COPD and stuff, but that will happen next. We'll talk about that next week. But in pneumonia, what happens is you have an infection going, the alveoli become filled with exudate or pus and white blood cells. You've got your immune system is kicking in and trying to fight this infection. What happens if your alveoli are filled with stuff?
Nothing can get in.
What?
Nothing can get in and pass. It'll
Right, because
prevent.
it's being blocked, right? It's all filled with this other stuff, and the oxygen and carbon dioxide can't diffuse back and forth. So what happens is that the affected areas of the lung then don't get enough oxygen, and gas exchange is decreased. And like any other part of the body, if the lungs don't get enough oxygen, they're not going to function correctly either, right? Also, our whole body needs oxygen. If you have a previous respiratory disease, if you have asthma, if you have COPD, if you have something else that's going on, the decreased oxygenation can lead to bronchospasms, so the bronchi clamp down. And then what does that do? What happens if your bronchi go from here to here? Your ventilation goes way down, and so it's like a vicious circle, isn't it? It's round and round and round. And then with all this, your pulmonary circulation then provides less oxygen to the body, and that's when you get hypoxemia, which means
low oxygen in the blood.
Low oxygen in the blood. Okay, good job, guys. So you have bronchopneumonia, which is the most common type, and it occurs basically throughout the lungs. It's in patches. Lobar pneumonia is when the entire lobe of the lung is involved. Okay, so there are two different ways to classify it depending on what part of the lung is involved and how much of it. So if an entire lobe is involved, it's lobar. If you hear the term bronchopneumonia, then you know that it's pretty much scattered throughout. And I've got a picture. So you can see for The heart is up here behind the sternum, okay? Lobar pneumonia, this whole part here, right in here, is all white. That's pneumonia. It's in that lower lobe of the left lung. Bronchopneumonia, you see patchy white, through here, some over through there, a little bit. It's more diffuse, so it's throughout the lung. But, you can tell the difference when you look at an x-ray. So, you guys over here, you see, here's the lobar, right here. Lower part of the left lung. And the bronchopneumonia is sort of scattered throughout the lung tissue there. Well, I'm doing good. I haven't killed myself on these cords yet. Presentation. And this is, you want to know how stuff presents, because when we have patients or clients come in, we're doing our assessment. You need to be aware of what you're looking at and to know what it might signify. So with pneumonia, the signs and symptoms of pneumonia can vary. For some people, you have sudden onset of chills, fever, pleuritic chest pain. It hurts when they breathe. And they may go into have some respiratory distress. Some people may present with an upper respiratory tract infection, like the poster. The lead fish is the common cold. So you may have cold-like symptoms, runny nose, the headache, the aches, the, stuffiness, all that type of stuff. But they progress to sputum production, flushed cheeks, and cyanosis. Sputum production, obviously, because you get more stuff in the lungs. Flushed cheeks may be from what? Fever. What's one of the things that causes fever? It's a systemic reaction, right? To what? To inflammation, okay? And the cyanosis is obviously, you've got less lung area that's going to be able to do your air exchange, your gas exchange. Orthopnea. A lot of people, the main sign of pneumonia is orthopnea, which is what?
Positional changes.
Well, you have to sleep sitting up.
Or just shortness of breath.
Yeah.
Okay. So, they come in because they're short of breath. Poor appetite may be a sign of pneumonia. It can be a sign of a lot of other things too, but it seems to go with the pneumonia. Diaphoresis and fatigue. And think about what's going on. You don't have the gas exchange that you need to have. It's going to do what to your activity tolerance? It's going to go through the floor, right? Because you need oxygen to be able to be active. Your cells need that oxygen when you're moving and doing things. If you aren't getting that oxygen, you're going to be tired. And I know people that have had pneumonia said it's one of the, it's not just you're tired, it's just like you're bone deep tired. It's just really draws you down. So fatigue. So again, when people come in and if they're have these complaints, when they're talking to you, these are the things you want to think about. And you might think pneumonia. But remember that signs and symptoms can vary with underlying conditions. So, the pneumonia may lead to fever. Is it shut off now? That's okay. When I was taking anatomy, when I was getting ready to go to nursing school, I thought I had my phone off, and it went on right during the lecture, and I had this little Jamaica type, reggae type music on, and my instructor just sort of looked at me and said, really? So it happens. But anyway, so the signs and symptoms can vary. Pneumonia might lead to fever, crackles in the lungs, but not always. You may just it may just be diminished in that area. You might have increased tactile fremitus because you've got air collecting outside of the lung, under the tissue. The lung tissue may become more dense. Any tissue when it's overworked is going to may become denser, thicker. So the lung tissue may become more dense. If you have someone that has COPD, They may not show any signs and symptoms of pneumonia because a lot of this stuff is already going on, right? You know, they've got the shortness of breath, they've got the decreased ventilation and diffusion and stuff because of the damage to the alveoli. So their only symptom may be the development of purulent sputum. The only way you might be able to tell for sure is because you're able to get a sputum sample and it comes back as a positive culture. So you can see how sometimes underlying issues can mask what's going on. And that can happen with a lot of different illnesses, but respiratory can really be one of those where it really can change how you present. It may lead to shock or pleural effusion. Again, the decrease in oxygenation affects the whole body. And also with the lungs, as you know, you're getting more, stuff is becoming more consolidated, you're not able to get stuff going in and out as well. May lead to effusion and stuff where you have more fluid actually building up in the lungs and around the lungs. And the elderly may appear asymptomatic, just like with UTIs. You know, there may not be a whole lot of symptomology, but someone's behavior may change a little bit. And again, when we're talking about cognition and oxygenation, if someone isn't getting the oxygenation that they need, in the elderly clients, all you may see is that change in behavior or the change in cognition. That may be the only clue. So it's really good, you know, it's really important to know your clients. And again, in long-term care, a lot of times when we're working with clients, that's the only thing that we see is something's a little bit off. So you need to be able to pick up on those cues. Those of you that work as LPNs in long-term care or assisted living know what I'm talking about. That sometimes it's just that little subtle change that says there's something going on. So with the diagnostics for pneumonia, and again, this is in conjunction, you know, with the provider, but you're going to look at a health history. The docs get their part of it, we get our part of it when we do our assessment, our admission assessments. That's the health history. You know, have you had this before? What do you have going on already? Have you, everything from, what types of medications are you on to? Have you been on antibiotics? Have you been hospitalized? Has someone else been sick? So you're asking and getting a full health history. There'll be a physical exam, okay? Then there may be chest x-rays, blood cultures, and sputum samples. And even though we don't order these, we're still working with the client to make sure that these things are getting done. We may be reassuring them, yes, this is a normal part of finding out what's going on with you because when your lungs are involved. It may be, okay, this is, telling them this is what we have to do. Maybe reassuring them, giving them information. It's okay to explain something to a client. If they ask you what something is or whatever, you can explain that to them. Okay, it's just when it comes down to something where there has to be consent and they have to know what the complications and issues could be, that the doc has to do that. But if it's, if a client says, well, why do you have to have a sputum sample? What does that mean? What are you going to do? It's okay to say, well, it's one of the things we use to try to figure out what's causing your pneumonia or your respiratory issues. This is what we're going to do. We're going to see if you can cough up something deep from your lungs. If you aren't, we may have to have someone else come and help you cough to be able to get that. It's okay to explain that stuff to a client. The worst thing for a client is to not know what's going on. So as nurses, we're going to make sure that even though a lot of these things, like I said, we get orders from the docs to do, there's a lot of stuff we do that complements and works with what they're doing. And again, we're looking at the human response to the problem. I don't know about you guys, but if I've got something that I'm short of breath, it starts to worry me. I get scared. I get anxious. I'm afraid things are going to get worse. We know how important breathing is. There's nothing worse than not being able to breathe. So think of the things, as nurses that we can do to help our clients when they're in this situation. Medical management for pneumonia, and again, I'm talking about this stuff because obviously we're the ones that are given the meds, right? So, you know, the doctors give us the orders, but we're the ones that are responsible for making sure that the meds get given when they're supposed to. They get right meds, you know, all that type of stuff. So, for bacterial pneumonia, antibiotics are what they start with. So, some of the ones, and again, I'll post the readings, you know, now that I know who's got what for the med book. I'll post the readings from that so you can read about the medications. Some of the antibiotics for pneumonia, ceftriaxone, ampicillin/sulbactam, levofloxacin, ertapenem. For resistant bugs, usually you're going to give them a cocktail. You're going to give them multiple antibiotics. Cephalosporins, aminoglycosides, and then either linezolid or vancomycin. Okay? Yes?
Do you want us to know specifics about these drugs?
What I want you to know, basically, is like with any other medications, you know, what might be some contraindications, you know, what are the side effects of them, you know, and I'll look through the reading and sort of let you know exactly what I want to do, you know, so like, that'll help you to know what to focus on for the study. But
So just to be clear, you're going to post additional readings
for the
March.
meds, yeah, because I wanted to know who had what book before I did it.
Okay.
So, yep. So usually, especially in the hospital, you know, because if you're getting IV antibiotics for pneumonia, you're going to be hospitalized. They're not going to send you home with a PICC line or anything. You're going to be put in the hospital. You're going to have IV antibiotics to start, and then as soon as the person's able to, they're going to switch them to oral antibiotics. So, you know, you don't want to be on IV stuff any longer than you have to be. And then as soon as someone is stable, then they want to send them home, because we know that hospitalization increases your risk, right? So here you are, you're already in there for pneumonia, you don't want to start getting better and then get it back and get it worse. So as soon as someone is stable, they're going to be able to send them home. So, you know, they're going to be monitoring what type of things do you think before they send them home? What types of stuff do you think that they would want to have be stabilized? Okay, you guys have to speak up for me.
Vital signs.
So vital signs, okay. What else? Their blood counts, yeah, okay.
Fever.
What?
Fever.
Fever, yeah, okay. Make sure they're afebrile. Yep, and they said that over here to the blood cell count. How about their oxygenation? I think I just heard someone say oxygen. We want to make sure that the person is able to be oxygenated and be able to get what they need that way. It doesn't do any good to send someone home if their stats are still running in the low 80s, right? Because we know the body needs oxygen to help heal too. So we want to make sure that everything is stable before they get sent home. But as soon as they are stable and able to go, we want them to be able to go home, because we don't want to keep them at risk while they're in the hospital. So the big concern now, though, for the medical management of pneumonia is just the rise in the resistant organisms. We're seeing more pneumonias being caused by, you know, VRE, MRSA, that type, the different organisms that are more resistant, and it's harder to treat them. And we know that, you know, if it's harder to treat, you know, more heavy-duty meds, it's sort of a vicious cycle. Because those bacteria are smart little buggers. I mean, they can mutate and change and adapt very quickly. So that's one of the reasons why, you know, we tell people don't overuse antibiotics, but they do anyway. So we also use, along with the docs, we have what we call clinical pathways and algorithms to help choose the best treatment options. So what we're doing is we have stuff that's already been figured out. Okay, if it's this type of pneumonia, we're going to use these medications, we're going to be looking for these results, this is what we want to see. So it's like, if this, then this. If this, then this. If not this, then this. You know, just like a decision tree almost, but it's already written out for you. Yes, Sarah?
And that's something the doctors would use.
Right, yep. But you need to know, what they are because it helps, like, a lot of the clinical pathways and stuff deal with both medical and nursing. And so it'll say, well, it's almost like a care plan where stuff is written out where for this is what we're going to be doing. It's almost like can't call it an order set, but it's a guide. And it's based on research, on clinical research, that this is what works best. And so this is what you want to do. Yeah.
Which is the more difficult to treat, viral or bacterial pneumonia?
We'll talk about viral stuff. I think they can both have their own challenges, but I think bacterial, especially if it ends up being something that is more resistant because of that. Viral, all you're doing basically is supportive care. You don't give antibiotics just for straight viral pneumonia. It's not going to do any good, right? Because antibiotics don't affect viruses. They affect bacteria. The only time that you'll see antibiotics given with viral pneumonia if there's something else going on that's bacterial in nature. But it's not for the pneumonia itself because it's not going to affect anything. So for viral pneumonia, you have the supportive treatments. Hydration, right? Why is hydration important with anything with this respiratory?
Loosen secretion.
It helps loosen the secretions. It makes it easier for you to cough them out, right? Antipyretics, both for pain and fever. NEB treatments to help open up those airways. Antihistamines, maybe to help clear some stuff up. Rest, have the person, you want them to get as much rest as they can, just let the body do its own thing to recover. Because a lot of viral things run 7 to 10 days is about what they run. And then oxygen therapy if needed. So, someone with viral pneumonia may be treated in the hospital if they need to have IV fluids for hydration. But otherwise, they'll just have them be at home and just do these supportive things. Make sure you drink a lot of water. Make sure, if you use Tylenol, for pain and fever, that type of thing. So nursing management, for our assessment, we're going to do a thorough respiratory assessment. And it doesn't just mean that you're just going to take a quick listen to the lungs. You're going to, ask the patient, are they short of breath? How's their breathing? Do they have pain? All the things that go with it. You're going to go more in depth because we're working with the respiratory system. Monitor their vitals. If someone has a bacterial infection and things start to go south on them, their vitals are going to change. If someone starts to go septic, their blood pressure drops, their heart rate goes up, the body's trying to compensate. Elderly clients, like I said, be alert for behavior changes, for altered mental status, dehydration, fatigue. Heart failure may happen in elderly clients when they get oxygenation. Why is that? Or when they get pneumonia. Why do you think they have heart failure?
The fluids are backing up.
Well, think about it.
Fluids,
What is the heart not getting?
oxygen.
So it has to work harder to try to get oxygenated blood back from the lungs and stuff, and so again, a vicious circle. So classic pneumonia symptoms may be absent in elderly clients. You have to remember that. It's like classic UTI symptoms. Getting old is a big adventure, but the body does change stuff. So stuff that we see in most people we may not see in our elderly folks. So we're not going to talk a lot about diagnoses, the collaborative problems and planning and goals, because I want you guys to talk about that when we do our case study. But these are the types of things that when we test you guys on it, we're going to be bringing into the exam. This is going on. What things might you need to watch for? What things might be issues? Or this is going on. What might be the best intervention for you to do in this situation? So that's the type of thing we're going to look for. Right now, like I said, I'm going to have you guys talk about it when we get it. We're going to do a small group thing. But some of the interventions, obviously maintain airway patency, ABCs, right? That's the main thing. Promote rest and conserve energy. Make sure you're promoting fluid intake, maintaining adequate nutrition. You're going to do client teaching, whether they're in the hospital or at home. You're going to teach them what they need to look for, what they need to do, what they need to be aware of, and monitor for complications. And then obviously we're going to evaluate it like we would anything else. Anything that we do, we want to evaluate whether it worked or not. Some complementary and alternative therapies that are used for pneumonia. Acupuncture. Theory being that it helps strengthen the immune system. Breathing exercises, coughing and deep breathing just to help pull more air into the lungs. And if you get more air in, hopefully there's going to be more ventilation and diffusion then. Garlic is one. I know some people think garlic is good for everything. But again, antibacterial properties. Essential oils, either by inhalation, where you do them with steam to help clear everything out, help open things up, or as ingested as a tea. So these are some things that people may try if they have pneumonia. Again, what do you have to be aware of with complementary and alternative therapies? Interactions with what?
Your medicine.
Any medications that you're on, or anything that may be going on already. Okay, so what I want you guys to do, I think not everybody is here, so let's see, how many do I want in the group? I think, let's do. How about if we count off by sevens? So 1, 2, 3, 4, 5, 6, 7, and then start over. So we'll have 7 groups. So Corey, you want to start?
1,
2, 3, 4. 4, 5, 6, 7, 1, 2, 3,
4.
5, 6,
7, 1, 2. 4.
6,
2.
3. What were you, Arthur? 4.
6, 7, 1.
Okay. So, how about if we have, I'll put the case study up on that screen so you can see it. So 1's up here, maybe 2's over here, 3's, 4's, 5, 6, 7. Okay? Group 1. Okay? What nursing assessment findings, and this is nursing assessment, support diagnosis of pneumonia. You're a nurse and you did your assessment, so.
The decreased breath sounds,
Okay, so,
the coughing and fatigue, the fatigue and shortness of breath.
okay, so shortness of breath, fatigue, okay,
The cyanotic lips and nails,
cyanosis, okay,
decreased pulse ox. Is that part of it?
decreased,
2 cents or
okay,
confusion.
Diaphoretic.
diaphoresis,
Weak cough without sputum.
is that indicative of pneumonia though?
Not specifically, no.
Because it could be, he's a COPD-er, right?
Yeah.
Okay. Anyone have anything else
Respiratory
for the
distress.
nursing assessment part that helps you figure out if you've got, what?
How about the vitals, the respirations, the increased respiration intent?
Okay, so he's febrile.
We had confusion.
Okay, confusion, and then increased temp. Okay. So those are things that you're gonna think with knowing what you do now, right? That, okay, that maybe this guy's got pneumonia going on. Everyone agree with what they said? Anyone else have anything else that they were thinking of?
Use of accessory muscles.
But does that necessarily mean that he has pneumonia? Because again, he's got COPD, so, you have to look at the underlying things that are going on too and sort of distinguish in your thinking, in your head when you're going through this, okay, what is normal for this guy already? With the COPD, you know, and the shortness of breath and fatigue may be part of that too. So, but we know that fatigue could be, especially if he sits there and he's just so, you know, laid out flat. Okay. Okay, good. So what diagnostic findings support the diagnosis? Chest x-ray, okay. What are his ABGs?
The white blood cell count is higher.
Is that ABG, white blood cells?
Acidosis.
Okay, so he's acidotic, right?
Yep.
Okay. So we know the gas exchange is impaired there. What else? Pardon? Pulse ox? Okay.
With the CBC
But again,
count
that
will
may be
help
related to the
diagnosis.
COPD,
Maybe
right?
infection rates. The white blood cells.
White blood cell count is elevated, okay.
Is pulse oximetry considered a diagnostic finding or an assessment finding?
Assessment.
It can be used in both directions. Again, it's not, you know, as accurate as other stuff, but it's a starting place. Yes, Rob?
What about low hemoglobin?
Low hemoglobin?
Yeah.
Okay, what? Right. Okay.
But does that mean pneumonia?
It may or may not. It may just be, you know, he's not getting enough iron in his diet. So what you want to look at is the things that you can see. So with the nursing part of it, again, these are things that, you know, we would be able to see in our assessment, right? We're taking vital signs, we're listening to his lungs, we're observing. When you're looking at his history, you know, the COPD and stuff, history of hypertension and diabetes that's controlled, which makes him more at risk, right? Because he's diabetic as well as the underlying respiratory. So, but you have chest x-ray, and the labs would really, in this case, that's really where your diagnostic findings, they're going to be the most important ones in this case, okay? Okay, what nursing diagnoses should the nurses formulate?
Do you want a different groups to answer
Yeah.
these? Like,
Yeah, group 3, why don't you talk about this?
Impaired gas exchange.
Okay, so one impaired gas exchange, okay?
Related to weak cough, as evidenced by use of accessory muscles and increased respiratory rate, cyanosis, low O2 stats, and diminished sounds.
Okay, think about what gas exchange is, okay? That's where you have your diffusion, right, across in the alveoli. So, related to, what was your related to? I couldn't hear you very well, Dave.
We had weak cough.
Okay,
I put lung consolidation.
do you think that that's going to cause impaired gas exchange? And that's just in general. What do you guys think?
Consolidation of fluids in the lung.
Maybe fluid in the lung, maybe something, you know, decreased lung function. So think about what, you know, we're talking about with the impaired gas exchange. And I know that's a common thing that, you know, I've seen in students when we're talking about respiratory stuff, that impaired gas exchange, you know, that they look at more the evidence rather than the related to. So, but remember that that's what's taking place in the alveoli if you're talking about in the lungs there, okay? Okay, any other nursing diagnoses though that you have?
That's the only one we did.
Okay. Group 4, what did you have for diagnoses?
The same beginning, impaired gas exchange related to ventilation perfusion imbalance.
Okay.
And as evidenced by his pH level.
Okay, so his gases were off, okay.
Right.
Did you have any other nursing diagnoses?
No.
Okay. Group 7, what about you? Okay. Okay, COPD though is a medical diagnosis. You can't use that as you're related to. Or you could say allergy to smoking. I mean, that would be, so. Anyone have anything besides impaired gas exchange for this guy?
Acute confusion,
Acute confusion? Okay, where'd you get that from?
the disorientation of time, and was it time and place?
Okay, so yep, so he's got some story on it. So how would you word that? Does acute confusion related to?
Decreased oxygen
Hypoxemia,
Or decreased oxygenation to the brain. Again, as evidenced by disorientation, you know, that type of thing. So that,
When you guys are looking at these nursing diagnoses, and you're trying to figure out the related to part, look at the evidence. You remember a couple weeks ago, we talked about, the last week we talked about how you do your analysis and you collect these pieces of evidence that you use to support your diagnosis. And this is what ends up at the end of your diagnosis. But think about what is the physiologic process that's causing that. So when you look at somebody who you know has pneumonia, because the physicians have diagnosed them and the lab data all comes back and says, yes, pneumonia, impaired gas exchange, what is the physiologic process that's causing that?
and we talked about, you know, what pneumonia does, that, you know, you have the inflammation, which leads to the, you know, the increased, you know, white blood cells gather, pus starts to form, you know, fluid starts to gather in the lungs and stuff. That's your physiologic process. That's
So you
your,
can have impaired gas exchange related to
inflammation.
Just a thought.
yeah,
What did he say?
lung congestion, maybe, some, you know, again, you've got that fluid building up in the lungs, the consolidation of the,
Or inflammation.
yeah,
Yeah.
so,
Could you say impaired alveolar function?
yeah, you can do that.
But if you're gonna when you use these, when you choose these, this tells you what evidence you're looking at, right? So if you're gonna say alveolar.
Impaired alveolar function.
Impaired alveolar function, what are the pieces of evidence that you have? And do this right now, tell me, what are the pieces of evidence you have from your case study to tell me that when you say impaired alveolar function, yes, you're showing me that, you're evidencing that.
So what's some of your evidence?
Like the O2 saturates?
O2 sats,
How about chest X-ray?
She's asked about it.
decreased breath sounds,
Chest X-ray.
The ABG results.
ABG results,
Okay?
okay?
So all I'm saying is, across your diagnosis, each one of these pieces supports each other. And if you do that, if you can mentally make those connections between these pieces, it's gonna tell you what your nursing plan of care needs to be.
And like I said last time, and Joseph said that too, your analysis, if you do it, you know, correctly and do it well, everything falls out of that. So the analysis is the big piece, bringing it all together. Yes?
Could you do like fatigue related to hypoxemia as evidenced by unable to finish a sentence without like respiration?
You could do that, but again, hypoxemia could be seen as a medical diagnosis. So what's the physiologic thing?
Oxygen.
Decreased oxygen levels as evidenced by. Yeah, you could do that. Because fatigue, like we said, is a big one because of that lack of oxygenation and pneumonia. Yep. Yep, ineffective lung tissue perfusion, ineffective whatever, you know, wherever you happen to think of it, because it's the whole body is being affected. It could be peripheral, it could be lung, it could be cardiac, it could be brain. Again, bringing the things that physiologically show why this is happening, and then as evidenced by what the patient is exhibiting. Okay? Does that make a little more sense? So, and again, it's practice. The more you do it, the easier it gets. We promise, right, Joseph? It does get easier.
It does get easier.
The more you do it, the easier it gets. Okay, so what goals should the nurse develop for the patient?
You want a different group?
What are some of the goals that, and remember that your goals you're going to develop in conjunction with the patient, if at all possible. So group 6, what are some of the goals, do you think?
Our goals were decreased pain, increased hydration, and increased oxygen.
You said decreased hydration?
goals,
And what else?
decreased
And increased O2.
pain, increased O2, increased hydration.
You mean SAFT? Increased saturation.
Yeah. Okay, any other goals for this guy?
Effective coughing.
Effective, that he will have an effective cough, okay. Okay, that's a good one.
How about carrying out ADLs without weakness and fatigue?
Okay. And remember, you know, if you're thinking short-term goals, how might you phrase that as a short-term goal? Angela?
Something measured.
Patient will, what?
Specific.
Be able to carry out ADLs without fatigue upon discharge? Or tomorrow?
Yeah, discharge, I mean, that could even be your long-term goal. What ADLs do you want to be able to do?
Will this be able to finish a sentence
Okay,
by tomorrow AM?
without having to stop for breath.
To stop?
Okay,
Was that one of the things?
okay, Ryan?
I'm curious about, like, we were going through stating goals, being quantifiable and defined by time. How can you quantify an effective cost?
Sputum production?
Maybe sputum production, or, you know, you can maybe, it's something like that that's subjective, but you know what his cough sounds like now, and what he's able to bring up versus what you want him to be able to do. So sputum production would be a good one.
Can't you listen to breath sounds before and after?
Listening to breath sounds before and after, yeah. Then after patient, you know, coughs, you know, his breath sounds will be, you know, will not be diminished or something along those lines. What else? Any other goals for this guy?
No confusion.
No confusion, okay. What? Lower respiratory rate, okay. So, decreased confusion.
And we wouldn't state these like these in our, care plans. We would do the whole sentences.
Right, you would say by, you know, the end of my shift, or by 2 o'clock, or, you know, after a NEB treatment or whatever, patient will. You know, you're making them specific, they're patient-centered, and they're measurable. Okay? So after a NEB treatment, my patient's, you know, O2 stats will increase from 85 to 90%. That's specific, that's measurable, it's patient-centered. Okay, any other goals that anyone came up with? Normal temperature, so AP route? Okay. So what overall interventions, we talked about some specific goals, but for this guy, what are some of the just general interventions we might want to do? Kelly? Oh, yeah.
If you wanted to say normal vitals or normal ABGs, but would they be normal with this COPD?
Right, so you have to keep that in mind. What is normal for this patient? Right, we know that COPD, a lot of times they live in the upper 80s%, right? Because of their lung function, the way it is. So you need to know what's normal with your patient. You know, so, and again, ABGs though, you know, are their standard numbers for that, but again, knowing what's normal for your patient. So you look at trends and everything too, so that's a good point. Be careful of using the word normal, because my normal, maybe Brianna's, as they say in Young Frankenstein, abnormal, you know? So because my normal would be different from yours, and from Rhoda's, and from Ryan's, and from Joseph's, and from Danny's, and so you need to know what's normal for your patient. That's a very good point.
We call that baseline.
Baseline, yes.
Spelled
Their
like
baseline.
Vaseline, but it's not.
Okay, so what overall interventions, so group 5, what do you have?
As we have a position patient since he has fluid in lower blood.
Okay, so just general interventions, you would have positioning, okay?
Once a week or what?
How often would you do that? Okay.
Deep breathing exercise.
So deep breathe and exercise? So you want to have them do deep breathing? How often do you want to have them do that? Every hour? Okay. Suctioning, if indicated. IS? Okay. How often do you want them to do the incentive spirometer? 10 times a what? 10 times an hour, okay. 10 times all at once, or do you want to spread them out? Spread them out. But believe me, there's patients that'll call you on that one. Well, you said 10 times an hour, you didn't say I had to do it all at once.
Violet.
Duh.
You're turning violet.
What other general interventions, overall interventions for this guy?
Increased fluid intake, ambulation,
Okay, increased fluid intake, okay.
dietary needs.
So helping him with his nutrition, okay. Mobility,
Medical administration.
medications. So there's a lot of stuff we can do, right? You know, when you think about it, think of all the things that we can do for this guy. Some of them are, you know, dependent or collaborative, like the meds. The suctioning we'd have to have an order for, you know, to do a PRN. But a lot of this stuff we don't need orders for. We use our nursing knowledge and our nursing judgment to determine what this patient needs, and we help provide that, okay? And that's what we're doing here. Okie dokie? Why don't we buy that clock? So it's stained, they have to be an acid-fast stain, if those of you that remember your microbiology. So that's fine, that's what they're there for. So, tuberculosis, Mycobacterium tuberculosis. I thought this was a cute little, he's got the little crown on his head, he's fixing a disease inside. So, the definition of TB is a chronic granulomatous infection caused by Mycobacterium tuberculosis, which usually affects the lungs. Okay? A granuloma is a chronic inflammatory lesion which is made up by accumulated macrophages. You know, so you've got your inflammatory cells and giant cells which make up a discrete granule. So what happens is the TB is in the spot in your lungs and everything, your immune system comes in to attack it all and tries to do that and get this pile of stuff collecting there, and basically then it walls itself off. And that's your granuloma, okay? By the numbers, 2012, 9,945 U.S. cases, with 6,274 of those cases being in persons who were born outside of the country. 91% of multi-drug resistant TB. Again, we have stuff that is becoming more and more resistant, is found in foreign-born persons. So most of the multi-drug resistant TB that comes in is coming in from people that are moving to the U.S. 1.3 million deaths worldwide, 74,000 of these were children. 8.6 million cases of illness worldwide. 6 to 10% of these 8.6 million cases are children. 1/3 of the world's population is infected. And what's the world population now?
7 billion.
7 billion. Little over 2 billion people are infected with TB. Okay. In high incidence countries, up to 40% of the new cases are in children. And I'm going to go back and find a link, and this will just be, you know, if you want a little bit more information about what's going on. Frontline not too long ago did a special on tuberculosis, you know, in the developing countries and the issues with treatment and how, you know, the problems that go along with that. And it's really a good program. I sat and watched it one night, and I was just floored. Even, with what I know, that, the stuff that, how it's treated, and, issues with medications, and make sure people take it, and the way it's spread, and especially in this, one happened to deal with how it was treated in Central Africa. And it was really something. So I'll find the link for that and just post it. It's something that, it's just something there if you want to get, just to watch it, just to see how stuff is handled in other places. That's right.
The number of children are high, so is it because they're susceptible, because their lungs are not well developed, or is
Okay.
there any other issue why?
Okay, Rhoda's saying, why is the number of children high? She's going, are they more susceptible? We know children's immune systems aren't totally developed, right? Think about, what's going on, especially in places that are very poor. What's the nutrition like? Okay, what's the regular health care like? There may be other people in the family, that are affected. So there's a lot of things that go into it, but a lot of it does have to do with the fact that our immune systems as children are not as fully functional as adults are. Good question. Some risk factors. Close contact with a person with active TB. That sort of is like a no-brainer one, right? That, if you're there with someone that's got it, you have more risk of getting it. If you're immunocompromised, again, what happens in someone with a competent immune system is they're going to, especially in the lungs, it's going to wall it off. So you may have it but never be symptomatic or anything because the body is able to seal it off. Okay? Substance abuse. Why do you think that is? What are some of the things that go along with drug abuse? Your immune system may be affected. What else? Nutrition issues. Hygiene. Okay.
Compromised living situation.
A compromised living situation. Yep. Okay. Good. Inadequate health care. We know that, if you aren't getting the health care you need, it helps, it keeps you from maintaining a health status that will help fight something off. Okay. Pre-existing conditions, again, because of the decreased immune system. Immigration. So people who are coming in from other countries, they are more likely to have TB when they get here because of the fact that they're coming from areas where it's more rampant. Institutionalization. It's one of those diseases that if you have people that are in jails, okay, especially, group homes, crowded hospitals, anywhere, where you have people that are close together, that you have, healthcare may not be the best, nutrition may not be the best. I'm not saying that it's bad, but it may not be optimum. Maybe harder to get the health care that you need. You're living cheek and jowl with people that may already have it, so you run that risk because you're close with people that have it as well. Overcrowded housing. And if you're a healthcare worker, yes, right? Why do you think we're higher at risk?
We're in close contact.
We're in close contact and then exposed. I had a patient one time that I was taking care of, and about a week later, I get a call from our occupational health nurse. She goes, just had to tell you something, because you need to know so-and-so was diagnosed with TB. Okay, he had been in a double room. He had no symptoms or anything because, so he was in a double room, everyone was in and out. So I had to go through the serial Mantos to make sure I didn't seroconvert. His roommates had to be tested. His roommates' families had to be tested. All the visitors had to be tested. All of us nurses, the dietitians, the therapists, the nursing assistants, anybody that came in contact had to be tested.
Did they know what phase or stage it was?
They didn't tell me that. All they said was that he was diagnosed with
Okay.
active TB. So I was lucky I didn't convert it all, so I'm okay. So my Mantos and my gold assays still come up negative. But, you know, it's sort of scary because you're sitting there going, crap. I don't want to have to do 9 months of meds. But it just goes to show that, you know, someone can have it, you don't know. Yeah, Allison.
What happens if you're a nurse and you get it? Can you not work as a nurse for some time?
You have to be on medication and you cannot work until they clear you. Yeah. Yeah. Usually it's, for most people, the medication, if you are diligent about taking the meds and, you know, do them like they're supposed to, most people it will take care of it, and then, you know, they will do Mantone. They'll also do chest x-rays just to verify. Because once they won't do a Mantone anymore. Once you've been exposed, you will always have a positive Mantone. But they'll do a chest x-ray, make sure everything is clear. And if they clear you, then yes, you can go back to work. So, yeah.
How long after that, how long are they going to be clearing somebody?
Well, the medications are generally 6 to 9 months, so you're probably going to be off work close to a year.
Do they compensate you or if you got it at work?
Do they compensate you if you got it at work? I mean, you would think it'd be workman's comp would help pay for everything. Yes, sir.
I thought you were considered not infectious after like 2 years.
But they still, a lot of times, though, they will still say that you need to have the medications and have them done. And the medication course is 6 to 9 months.
Is that just because of being a nurse, not other professions? Or are you talking about?
I don't, you know, I'm not familiar with how other professions do it. So,
It's going to depend on your employer.
Yeah.
Your employer will make decisions based on their own policy.
Yeah.
I'm actually seropositive, and when I converted, the state paid for my medication for 6 months.
okay.
And I didn't have to pay for anything, but I didn't have any limitations, but I never had active TB.
You were working
I was
in your
just
lab, right?
exposed to it, so-
Software.
Actually, I think I was exposed in high school.
Oh, okay. Okay.
So you had to start the prophylactic antibiotics, or?
No, you take, there's a drug called isoniazid that you take, and what it does is it eliminates any spores or eggs, or it eliminates any residual microscopic disease. So with TB, you don't have to ever have active TB in order to seroconvert. All you have to do is be
Been exposed,
to.
yeah.
So the isoniazid is a drug that you use to assure that you do not ever develop active disease.
Okay.
Most people who seroconvert to be TB positive will never develop active disease. But
It's
the
what, like
drug
10% of them or something as well. It's a small number. Yeah, question here.
I've seen a patient with active TB admitted in hospital for like months.
Right, yeah. Yep. She was saying that she's seen patients admitted to the hospital and be there for months with active TB. That can happen. There's a question over here. Kelly,
So do standard precautions help you, or should you be doing something extra as a nurse with any new patient because you don't know what they have?
And that's a good question. Kelly's asking if standard precautions help, or should you do anything extra? Precautions for TB are airborne precautions. Okay, so you have to have the negative flow room, you have to have the N95 masks, all that type of stuff. Okay, it's cost prohibitive to do that for every single new patient that comes in. There's not enough rooms, you know, the respirators, all that type of stuff. So, from what I've seen is, you know, we'll ask people, you know, about the risk factors for TB, but you can't assume that everyone that comes in has it. But you can, you know, you ask for risk factors, and if there's a lot of risk factors, you know, if you note that type of stuff, then you would see if, you know, just, that would be part of your assessment, and that's something that the docs do look at when they're doing their work with the patients, and so then they would see that and, you know,
Is
dig
it
into
only
it
when they're
farther.
coughing and you could get it right there, or is it just floating around in the air?
Well, you know, if they coughed and, you know, you're not in there, but just be floating around for a little bit, but, you know, so it's one of those things that, like I said, we can't just, I guess, you know, you could assume that everyone has it, but we don't have the facilities to be able to put everyone that comes in into the proper airborne precaution type
Some
area.
people spit when they talk. when they talk, so.
Yeah, so, you know, what are you gonna do, right? You know, say it, don't spray it, that type of thing, yeah. And that's true, though. You know, it's not just from someone coughing that they spread, yeah, Rose?
Yeah, I just want to clarify about the 2 weeks you mentioned. While I was reading, the 2 weeks is just, the patient won't be contagious as it was before. But the patient himself has to finish wherever
Yep.
the medication is. With 6 months, the patient has to finish.
6 months to 9 months, depending on the treatment, like drug cocktail they have to use, yeah. Yeah, so, and again, it's gonna depend on your facility, how long they say you have to stay out. So, because again, remember that the facilities, especially, you know, acute, well, wherever you are, acute care, long-term care, clinics, anything like that, you're dealing with others that are gonna have immunocompromised issues, having underlying diseases and stuff. You wanna be very careful that you aren't inadvertently making someone else sick. Yes?
So then they just keep on doing continuous testing to see if it's active or, you know, to
Joseph,
determine whether it's.
they aren't going to do, how frequently do they test you? They test you more, I know, for the side effects of the meds, but they don't test you for the TB every week or whatever.
Right, so there's no test that tells you your disease is active. The disease presents symptoms and signs.
If it's active, yeah.
So, and also your lungs are the primary site of active disease, so you get a chest x-ray. And I know there's many people in this room probably who are seropositive, and you know you have to have a chest x-ray on a regular basis. That's to look for signs of infectious disease.
Right.
Once you seroconvert, you are always seropositive, so you should never have a skin test.
Again,
ever.
yeah.
Because you can actually develop an anaphylactic reaction to the tuberculin serum that they use to do the skin test. Probably not, but it's a risk. So it's not that they can test you and say, oh yes, you have active disease. They need to actually go looking for it. If you're presenting with symptoms that you can detect, your disease is pretty advanced. You need medical attention. So, you know, that's why we do the chest x-rays on a regular basis, is so that you can make sure you don't have it.
Because they may do that periodically while you're on the medications, just to see if things are clearing up.
Right.
So, thank you. Yeah.
How about the gold test, the blood test? Because with the Mentos, most of the, you know, like people from Asia and Africa, they get BCG vaccination, and that makes positive Mentos, even if you are not, you know, positive.
Right. So if you're TB positive, you're TB positive. It doesn't matter what test you use.
Yeah, because the BCG, you come up positive afterwards, so you have to have a chest x-ray.
So even the gold
The,
test.
yeah, the quantiferon gold won't work. So, and it's not just people, you know, that have come from other countries. My husband has to have a chest x-ray because when he was a little kid, they thought his grandma had TB, so they vaccinated the whole family. So now, you know, he worked for Metro Transit for 23 years, and obviously you're working with the public and stuff, so they really write herd on all that type of stuff, and he had to have a chest x-ray with his physical because they couldn't do the Metro.
They do every year, the chest x-ray?
That's a really good
Yep,
question.
because it's changing.
The evidence is, so the evidence, the research-based evidence says there's no need to do an annual chest x-ray. Nevertheless, many healthcare employers, including our clinical partners, demand that you have an annual chest x-ray.
Yeah.
That's why if you guys are seropositive, you know we require an annual chest x-rays because your clinical sites require you to have an annual chest x-ray. Once you're out working, it'll depend on your employer's policies. Most places that are not hospitals will probably not require you to have an annual. Once you have one chest x-ray that shows you don't have active disease, you wouldn't be tested again unless you're symptomatic.
Right. But in hospitals especially, it's a yearly requirement. And most hospitals,
Not as anything concrete.
well,
Some hospitals.
that's, okay, most hospitals, I know where I worked, it was in,
Every year.
yeah, Fairview, if we had to have Mantos done every year. Or if not the Manto, we had to have the chest x-ray, at least when I was there. So, again, it's gonna be site specific, And, you know, the thing is with hospitals, again, you have a lot more chance to be exposed to it, and you have a lot more people that are gonna be, that you could infect. So, the pathophys for TB is the bacteria are inhaled and the person becomes infected. That's how you are gonna get it. You're going to, most part, get it, you know, through.
Airborne.
Get airborne. I've heard once in a while that if you know, drink like milk from infected cows or something, you could get it, but for the most part, what we're gonna see here is gonna be inhaled TB. So the bacteria settle in the alveoli and start to multiply. So again, you're going to have that alveoli involvement. Yes, Elias?
Quick question on the BCG. If you get a false positive with the BCG, can you still get the anaphylactic reaction? Or
If you have had BCG, you will not have a mantle because there's the false positives happen so much. If you have a BCG, you have to have a chest X-ray. They won't do a mantle at all. So you would be reacting to the mantle. Okay.
So if it's done many times, it gives you basically a risk of having the anaphylactic shock, or?
If you're, what is it, if you're TB positive, if you're seropositive, but he's asking about the anaphylaxis that you were talking about. That, because the BCG, you're not going to have a mantle, so that's off the table, okay? You're not going to react to the BPD because you aren't having one. But if you have the mantle when you're seropositive, you said something about anaphylaxis was a possibility.
Right, well, okay, so if you're seropositive to TB, regardless of the test that you use to detect it, what are you detecting? What is your body doing that we're using to create a test? What do we test for? Antibodies. We're looking for antibodies, okay? So your body produces antibodies in response to things you've been exposed to. So you don't necessarily have to have the disease, but if you've been exposed to tuberculosis and you've somehow gotten proteins into your body, whether you inhaled them or however, that are from the tuberculosis bug, then your body's going to produce antibodies in response to that. Because you're producing antibodies, your antibodies are what can cause this anaphylactic reaction. Now, it's not very likely that you will have an anaphylactic reaction, but it's possible. Your reaction can be quite severe because they're putting that toxin into you. The toxin is different from the actual pneumonia bug, right? Pneumonia cystis. It's a toxin that's secreted by a colony of them. And so this response that you have can be elevated. It can be quite a bit stronger than it would be because you already have these antibodies present. And that's all we're looking for is that response that says you have antibodies.
Yeah. Thank you. Okay. Next.
Can you give blood if you are seropositive?
Yes.
Okay. So you can donate, okay? Yes.
My question is, every immigrant coming has to have a PPS first, PPD, sorry, then you have the reaction. Even if you don't have the reaction and you had a BCG, you are fine. You don't get the chest X-ray.
Okay.
So the problem is, how do you know who has a BCG can have a reaction, or who has BCG cannot have a reaction?
That I can't tell you.
Yeah, does everyone have to have a chest X-ray or not?
Pardon?
Does everyone who had a BCG has to have a chest X-ray or not?
My understanding is this may change, you know, with the immigrant policy and stuff too. And I know they're looking at, because TB, you know, for a while was on the rise, they were looking at how to change things. I'm not sure if every person that has had a BCG, if they have to have a chest X-ray when they come in. I'm not up on the immigration status. But the fact that you can have a false positive mantle, for a lot of times, I know they say it's just easier just to do the chest X-ray then and get that done because then you can tell. So, okay. One more question.
The chest X-ray is, remember, the chest X-ray doesn't test for anything.
No,
All
it just
does
shows.
show what's there.
Yeah,
Okay.
yeah. So it just shows that there's active disease or not. Elias, one more question.
Yeah, no, but the same question is just, with the BCG, I was thinking, because antibodies are, does the BCG increase your antibodies?
It's
or-
because it was a vaccination, is what it is. It's an immunization. So the whole idea is that it's going to increase the antibody. Yeah. Okay. So, anyway, so the bacteria settle in the alveoli, begin to multiply, and can also spread through the body through the lymph system. So you can get tuberculosis in other places than the lungs, but it's in the lungs is when you can spread it, because you're going to be inhaling and exhaling, and it can be treated. So the immune system begins an inflammatory reaction, like with any other disease. You have exudate developing around that area in the lungs. Can cause bronchopneumonia. Remember we were talking before, so stuff could be related. You get the same beginning types of presentation. And then you have the formation of the granulomas, which again is that walled off spot in the lung that sort of says, aha, I'm going to seal you in and you aren't going to be able to do anything. And for a lot of people, that's as far as it goes. You get exposed to it, your body starts to fight it off, you might get, some little bit of pneumonia, but then it'll seal off the tuberculosis. Okay? It's when that granuloma breaks open and stuff can spread again. That's when you start having active disease. But for most people, it gets to that granuloma stage and that's where it stops. Okay? So active disease can happen if the immune response is poor. The dormant bacteria can then reactivate. It spreads throughout the entire lung. And I said it can occur in other parts of the body due to spread by lymph. And that's called miliary TB. Not military, miliary. And if you're writing about it, every time you try to write about it, spell check in all its wisdom will always change it to military. It's really obnoxious. But it's called miliary TB. That just means TB that has spread from the lung to other parts of the body. Okay? So if you see that phrase on somebody's chart, that they had miliary TB, then you know that it immigrated. Okay? So, a couple of pictures just to show that TB can go outside of the lung. The left side is a tubercular lung. And what happens is you have your alveoli development and stuff collapses and so you get little cavities throughout the lung tissue. That's one way that it presents. Cavitary tuberculosis, they call it. This is a person's testicle and spermatic cord, where the TB, did I hear carumba back there? Where the TB spread. So you can see all the damage to the tissue. It had to hurt. When you think of the nerve involvement and everything in the genitalia, that had to be really painful. But it can spread to bone, it can spread to the brain, it can spread to the heart, it can spread throughout the body. So, presentation. I sort of like this little cartoon. It sort of says it all, really. The TB, the germ is awake and causing harm to the body when you start having a presentation. Cough for more than 3 weeks, night sweats, fever, extreme tiredness, weight loss, and no appetite. And some of them, again, think about it. What else could present like this, right? We just talked about it. Pneumonia. Some of this could go with pneumonia. The cough may be non-productive. Okay? Hemoptysis is possible. If anyone has ever watched Tombstone and Doc Holliday at the end, he puts his handkerchief up to his mouth and it comes away all red, right? John Henry Holliday had tuberculosis. That's what finally killed him. The guy was, good with a gun and everything, but he died of tuberculosis. So, that was one. Anyone in here ever read the book Little Women? Most of us girls probably have at one point or another. Remember Beth in Little Women? Consumption. She died of tuberculosis. It used to be called consumption because it consumes the whole body, basically. Okay? As it progresses, you lose weight because your anorexic, so you lose weight, you become weaker. It consumes you. Yeah, Kelly?
Do these symptoms, are they severe enough where people will seek medical attention or will they ignore?
A lot of times these symptoms are things that people will ignore. That's why, where you run into issues because people ignore them. So, these symptoms are going to be chronic, okay? So once you develop it, you're going to have these things and they're not going to go away by themselves. You're going to have them and they're going to turn from an acute into a chronic illness. It'll go on and on and on. Again, older adults have a less pronounced presentation. Some of this stuff, night sweats, okay? Well, I'm going through menopause. That happens. Those of us that have gone through it or are going through it know all about night sweats. Okay? Extreme tiredness. Well, my job is really, I work, every week they always want me to work an extra shift, and I do it, 3 12s every week anyway, and I would put in 1 or 2 extra weeks, so I'm tired. So, no wonder I'm tired. No appetite. It's just, nothing looks good. Weight loss is like, cool, my diet's working. Oh. So, these things can present, and people, I think part of it is, one, people aren't aware, but 2, people, maybe deep down they might be aware, but up here it's saying, nah, that's not it. It's something else. So, it's stuff, and sometimes things can be so subtle that you really don't even notice them in your busy day. You're busy with kids, you're busy with work, you're busy with school, you're busy with church, you're busy with extra activities, your parents, whatever the case may be. You don't pay attention to what's going on. But older adults, again, will have a less pronounced presentation. So it's important to, again, be aware of their baseline. So like with pneumonia, you may not see the things that you expect. Because we know a lot of times with older adults, the sense of taste can diminish. There may be some anorexia, there may be some weight loss there. Night sweats may be due to hormonal changes. So, and they may not present the same way. It may be a more subtle, where someone, that's full-blown, maybe totally over the top with the way they present. Elderly adults, it can be a lot more subtle presentation. So you want to, again, your assessment skills really are important here. And then in non-HIV patients and up to 16% of TB patients, you will see it extrapulmonary. That means it goes outside of the lung. So not everybody has it where it spreads, but about 16% of the patients will have it spread somewhere else. So some of the diagnostics, the MANTO, the PPD, or purified protein derivative tests, like we were talking about, maybe false positive to BCG. The blood test, the quantiferon or TB Gold test. This is just checking, again, checking to see if you've been exposed to it. But this, from what I was reading, is not affected by having had a BCG. So that's something they may do. If you have had a BCG in the past. So there again, it would help eliminate the need for an X-ray. Let's do the quantiferon Gold. Sputum test. One of the most important ways to diagnose it, because when you cough stuff up, you're going to cough up those little bugs with it, and that's how you can tell for sure if that's what it is. History and physical, so the docs are going to ask, about your risk factors, about what symptoms you've been having. Chest X-ray is going to help confirm whether the disease is active or dormant. And then after you have been diagnosed, they're going to do drug susceptibility testing to see if you've got something that the regular drug regimen will be able to knock out, or if you have to take something stronger because you've got a resistant strain. So they're going to do that after they confirm the diagnosis of TB. They're going to check for drug susceptibility. So when you do a MANTO, and this is stuff that you need to know, because I might ask you, well, you've got this person and this is what their MANTO looks like and what does it mean? So you need to know this stuff. So reaction is positive when you have both induration and erythema. Induration is the hard part of it. You know, you get the lump in the middle of it. And erythema is the redness. So if it's red without induration, it's not a significant finding. Every time I have a manto done, I get a spot about the size of a $50 that turns red on my arm. That's just, I react to just the irritation of the injection that way. But I never have any induration. So, you know, they always look at it and they go, oh, okay, and then they, you know, the reads, it just feels that there's no swelling there, you're fine, it's negative. Induration is measured in millimeters at the widest part of it. So if you have, say someone, you know, that they've got a red spot there on their arm, and their induration is sort of like that, they're going to measure across the widest part, you know, depending on how it lays. So that's how you tell how many millimeters it is. You measure at the widest part. The size of the induration is how they figure out the reaction itself. So normally 0 to 4 millimeters is considered not significant, because there's always just, you know, that little bit of a reaction, you know, to having an injection and stuff. So 0 to 4 millimeters, they're going to say, you know, it's 3 millimeters, okay, it's still okay. It's not, you know, I'm not going to worry about it. 5 millimeters or greater is considered significant in people that are at risk. And in HIV positive patients or people that have HIV risk factors, have close contacts with TB or have a chest x-ray that looks like you have TB, they will say 5 millimeters is a positive result. Okay? In people without these additional factors, it would be considered significant, and they would go and keep doing further testing to figure out if it's actually TB or if it's just the way you reacted to it. In people with normal immune systems, 10 millimeters or more is considered significant, and that means that they're going to go through and do further diagnostics. So it makes a difference, obviously, if your immune system is intact or not. Okay? And they set it up this way because people with lowered immune systems, you know, you want to make sure that you're getting stuff going quicker and getting the stuff that they need, because they do have that issue of being immunocompromised. So, any questions so far? Okay. Medical management, and again, I'll put the pages up, you know, for you guys to read about the medications. And there's also some in the book about them as well in the textbook. So use of anti-TB agents for 6 to 12 months. Most people usually take use 6 to 9, but sometimes they have to go up to 12. Length of time is necessary to eradicate the bacteria, like Joseph said, to make sure everything is gone and to prevent relapse. Because like with anything else, if you only take a little bit of the meds, you're more likely to have it come back. And it usually comes backwards because the bacteria have had a chance to adapt. So TB is becoming more resistant to be taken into account when people are planning therapy. So you have primary drug resistance, which is just it's totally just resistant. Secondary or acquired drug resistance, where you haven't taken all your antibiotics and it gets resistant to that drug that you were doing. And then you have multi-drug resistance, which the Frontline Special focused a lot on the MDR TB, the multi-drug resistant, because that's happening more and more, you know, in places where TB is widespread.
What was the primary?
Primary is just that it's resistant just to those primary drugs that you are going to use. You know, we have our frontline drugs that we use. So the drugs, the isoniazid, rifampin, pyrazinamide, and ethambutol are the main ones. And again, I've got the pages if you've got for the textbook listed there, and then I'll also post the pages in the Karch book for you to read about these. Again, you want to know what they are, you know, the class, you know, basically how they work. You don't have to get into all the molecular and cellular stuff, but know, how they work, how they're used. And with these drugs, a lot of them are used in conjunction with each other. You're not going to give just one. You're going to give generally 2 or 3 together. Nursing management. Promoting airway clearance. Again, yes, the lung is involved. Promoting adherence to treatment regimen. This is a big one. These meds have a lot of nasty side effects. These meds have to be taken daily for a long time. And people don't like to do that. People don't like to have to take meds all the time. It's no fun. People don't like having to deal with how the meds make you feel. Sometimes it's like the cure is worse than the disease. I'll take the disease any day. People, may not have insurance. People may be afraid of doctors. People may have other issues, especially mental health issues that would keep them from getting the treatment they need. Okay? So think of, as a nurse, what do you have to do with these patients? With patients that, you have this drug regimen that is difficult. It's long-term. Yeah, Allison.
Like help them come up with some kind of schedule, or help them work as a team to figure out the best way for them to comply.
Okay, so help them maybe come up with a schedule.
Teaching.
Teaching. What are you going to teach them?
Why it's so important.
The long-term consequences of...
Okay, why it's important, what the long-term consequences are. I will tell you, in some areas where there's a lot of TB, especially inner city areas, there are public health nurses that their only job or task is to go to TB patients and make them take their medication every day. That's all they do. They go out into the field, they find, they have their list of people that are on medications, because it's a reportable, obviously, to public health, right? So they have their list of people, they go with their doses of meds, for each patient, and they literally go sit there while they take them, and they do that every day. So think about it. Think of the resources, one, that takes. The places where you don't have those resources, what happens? A lot anyway, what might happen?
Spread.
People, they quit taking their meds. It isn't just skip a day, they just quit. So then you have, the chance where you can spread it, and you also have the risk of developing more drug-resistant and multi-drug resistant strains of TB. Yes, Ron?
Yeah, I was wondering, I used to work as a medical interpreter, and sometimes I used to visit these kind of patients.
Mm-hmm.
It's very expensive to have a nurse and interpreter, because
It
it's
is.
gonna cost. Because while I was there, I was getting $40 an hour just watching that patient take the medication itself.
Yeah.
So is there any other way we can teach the patient the importance of taking the medication so we can cut down that cost?
Rhoda's asking if there's any other way we can teach the patient. And we do. We teach them what the meds are, what they're for, how to take them, why they need to take them. But, unless you're standing right there, we can't make someone take something. And it's trying to get them in that mindset where, yes, I have to do this. It's important for my health. It's important for the health of others to do this. But how do you do it? Like I said, places that can't afford someone to stand there and watch someone physically take their meds. It's really, it's a big public health issue. Yes, sir.
I have a question about the next one, promoting activity. I would think with the fatigue, you would want to promote rest more than activity.
Okay. That's, I'm glad you brought that up, because Rowan was asking about that too in relation with pneumonia. You want someone to be able to rest and stuff, but then we say to promote some activity. Again, you have to balance what's going on with physiologically with what we know that mobility is important for. And so you're going to use your nursing judgment to balance that. Yes, we need you to rest, but yes, we don't want you laying in bed 24/7, unless you absolutely cannot get up. You need to at least get up and try to mobilize a little bit, because we know that being in bed has its own problems, especially with oxygenation and with the lungs. And we already have compromised lung tissue now anyway. We don't want it to get worse. Good question though, thanks for bringing that up. So promote good nutrition and promote transmission of infection. Assessment, respiratory status, living conditions, and ability to understand the situation. This one. Yep, that's my understanding. Yep, you have to start all over. So. And I'm not sure how many days, you can miss before you have to start. I'd have to look that up. But I know that, taking that they start from the beginning. Yeah, of course. So, again, assessment, respiratory status. We're looking at living conditions, and again, ability to understand the situation. If someone doesn't understand why this is going on and why they have to do this, they're not going to be as able or as willing to do what needs to be done. So you need to really assess, how well do they understand it, how well can they keep doing what they need to do. Again, diagnoses, goals, and interventions. Think about these. I've got a little case study for TB posted on D2L. We're not going to get to that in class. But look at it. Those, in a lot of ways, make good study guides too, because you're answering the questions and thinking about it, and thinking, how as a nurse, would I do this or this or this? So think about nursing diagnoses, nursing goals that you would do, interventions you might do. But again, remember, the most important interventions to help the client follow the medication regimen and help keep the disease from spreading. Everything we do with TB patients, especially, with active TB especially, but even, if we're treating them for non-active disease, if we need to, is make sure that they understand what's going on, why it's going on, and to make sure that that disease does not spread. Okay? Because, you get in places in close quarters, people that are malnourished, maybe, haven't been to a doctor, immunocompromised, and it literally can spread like wildfire. It can go so quickly from one person to the next. So the biggest thing is education. Education, education, education. Okay?
So,
Yes, sir.
Did you say on the recommend the previous slide, promoting transmission of it?
Preventing, it should be. Okay, promoting. Oh, yeah, it should be preventing. That is not what I want to say. That's not what it's supposed to say. It's supposed to say preventing. So I will fix that and repost the slide. But yes, you're trying to prevent all this from spreading. Thank you. So, complementary and alternative therapy. And again, there's people that with something like this are going to be desperate for anything, right? They want to get rid of it, and, especially when they find out they're taking 6 to 9 months worth of meds. So, tuberculosis cannot be cured with anything other than the medications that we have for that. Okay? So, bee pollen or whatever, none of that stuff is going to help. Now, people will try all sorts of stuff. It's not going to make any difference. There are things we can do to help alleviate some of the things that happen in the body because of TB. Okay, so we can use complementary and alternative therapies for symptom management and for well-being, but nothing is going to cure TB other than medications. Like acupuncture, again, some people will feel that it helps with the immune system. Anything that helps with the immune system makes it easier for you to fight off disease. Yoga. I was reading about one study where they were saying that yoga, the relaxation and the meditation and the breathing, the rhythmic breathing of yoga can help because it helps with the oxygenation.
Now, do you have to do yoga in a negative pressure room? I'm just kidding.
Only if that's where you happen to be at the time. If that's where they got you stuck, you're going to do your yoga, the negative pressure room. But the idea of yoga, again, one, the calmness, we know that stress affects the immune system, right? And yoga helps you relax and helps you, become more calm. And then the breathing exercises. And the deep breathing and stuff that goes with yoga, the centering. And if you don't get into yoga, you can just teach someone how to do just regular breathing exercises, the deep breathing, how to do that. Diet, again, we know that if you're malnourished, it's going to affect how you're able to fight off the disease. And then again, garlic, because some people think that it's just general all-around immune system cure-all. Again, it's not a cure-all, but there's nothing that says it doesn't help. So, but again, be aware of interactions and stuff that go, with using any sort of herbals. So, I've got my references here. And like I said, I'll post the link to that Frontline show on D2L. I've got the TV case study posted that you guys can use for, do this. Again, it's not required, but it's there to help you study. So, are there any questions? There's a lot of information, I know that. What I'm giving you is an overview. So, hopefully it'll help you guide your studying and stuff. But if you think of the nursing process when you're studying, guys, what nursing, what data would I be getting? What nursing diagnoses can I come up with? What are my long-term and short-term goals? What are my interventions I could do? How do I evaluate them? What education goes with this? That's a big part of it. You're bringing all this information together. You're integrating it. That's what integration is, bringing it all together and figuring out what you want to do next. Okay? So any questions? Appreciate your time. Anyone in clinical that